So this will be the last lecture that we'll do today. Thank you so much for just going through this and interacting. It makes my job much easier. And obviously it's a big day, lots of information, but it's just to give you the frameworks and these structures that will hopefully keep you in really good form for the rest of your careers. Okay, crisis resource management. So what is CRM? Pretty much, everything we've done so far is very unidimensional problems. You've gone through a very unidimensional problem where there's one issue, maybe two, and you've got just one management thread to solve that problem. Now, a crisis obviously is when lots of things are going wrong. There's lots of tasks to be done. There's a really serious outcome. Death is obviously the end point of a lot of the problems we have in anesthesia. And there's a time constraint. You don't have enough time to take all the luxury to sort something out. And this is just inherently every bad thing that happens in anesthesia can be a crisis. So what do you need? You need hands, you need brains, you need priorities. So even as a relatively senior anesthetist now, I may still not know what's going on. So I need extra brains to help me solve a problem, or I need lots of expertise to get things done. So whether I'm the leader or not, whether I know what's going on or not, I need both hands and brains. And then I need a really good set of priorities and anticipation and timelines, and then flawless communication. So CRM, this refers to all the non-technical skills required for effective teamwork in a crisis situation. Now, the longer I work, the more I realize that this is absolutely everything. I started, my first year of medicine was in the year 2000, and the first time I heard about CRM was 2012. It's really crazy to me that it took 12 years for me to learn the words, learn the thing that I think is now most important in my practice. Imagine if you were a pilot and only heard of what a plane was 12 years into training, or if you're an infectious disease specialist and only heard about penicillin 12 years into your training. So this is really new and really, really relevant. And it's a space where you may have not heard it now, but you'll be examined on this. You'll be tested on this. Interviews will be conducted with this. And we've already started doing interviews with CRM as part of your part of your formative assessment, even though we're not grading on it yet. But again, we may be doing that in the future. So I need you to know this now. I've just given a link in your workbooks for a really chilling insight into human factors and how they can go horribly wrong, and really a prompt for why a lot of the airway management stuff has come out. So how do you do CRM like a boss? I want you to create systematic steps to integrate CRM, crisis resource management, into your existing knowledge of management, and then use these problems to solve complex, multitask, time-critical problems, and most importantly, do a CRM like a boss. As I was searching for these little images, I just realized, wow, there's really not too many representing females, so here it is. Now, crisis resource management. This is a massive list of things that Rall and Gaba in 2005 published. Now, have a look at these, a lot of good words, but something I really hate is just words without actual context and actions to have them. So you can say a lot of words in medicine, but to me, they mean nothing unless we know how to apply them. So let's look at the CRM principles and learn how to apply these in a real context. So when I looked at all these principles, I've just labeled them on the left-hand column, and there's a whole bunch of words, right? What I found is that they all really, really easily can be allocated to an action. Call for help, emergency buzzer, phoning someone, whatever that is. I'll skip the next one. Leadership, good teamwork. So leading the situation as you get more senior, you allocate staff to a role. As a junior, you may be the one saying, who is leading this? You may be the one prompting someone to take ownership and leadership, because when we run sim, that's what changes the situation dramatically, finding out who that leader is. And you can be part of that solution. Who is the leader? Who's leading this? Let me know who I need to follow. Using cognitive aids, they're everywhere now, whether it's on your phone, looking at the ALS flowcharts, or on the crash cart. There's anaphylaxis boxes, various flowcharts for rhythm management, MH trolleys, etc. You always want colleagues there to confer with, second opinions, and then you got to anticipate where this is going. Do you need a call for ICU theater, call another consultant, reg external help? And imagine if you don't say these things, it shows me that you haven't run an arrest, you haven't seen the situation, and it's so easy to say these in the context of an exam, but also think about these in real life. Now, everything in black on the right side is completely constant. It's very similar no matter what the case is. But what I've realized, the point of difference or the critical difference in issues in these cases are stating the multiple priorities. Remember, the problem solving we did before is unidimensional. Stating the multiple priorities allows you to allocate multiple threads of management, which is what happens in real life. Think of any trauma in ED. Someone's doing lines, someone's doing the airway, someone's doing blood management, someone's doing assessment, someone's doing x-rays. What you want to do in anesthetics now is identify what your multiple priorities are, have a go at that, and that way you can allocate your resources to each multiple priority thread and be able to tell a story for each. That's what we're going to work on now. So 35-year-old female for lap appendicectomy. You're at a small suburban hospital, think Williamstown, Sandringham, 4 theaters, no ICU or CCU. You induced this otherwise well 35-year-old with no allergies for an open appendicectomy. 1 minute after induction, the blood pressure drops to 60. The patient is difficult to ventilate with high pressures, only delivering maybe small tidal volumes. So just quickly, someone tell me, you're allowed to call this something until proven otherwise. What do you reckon it is? Anybody?
Anaphylaxis.
Right, you are. So I want you now to turn to your partner and take 2 minutes and talk through the scenario and try to put as many of these extra points in to involve CRM in your management. And then what I'm going to ask someone is, aside from all this extra stuff that we talked about, which are very important, I want someone to tell me their multiple management threads. And we'll then talk a story about each of those. So take 2 minutes to talk out this scenario. So I would say something like this: very concerning. I call for help. I check my reading, repeat the blood pressure, scan all my monitors. And in this particular case, finger on the pulse as well, because I'm really concerned that the patient might arrest, and then tell the surgeon to stop. This is potentially anaphylaxis. My temporizing measures are just what we've gone through before, but I've now combined 2 of them: fluid metaraminol, 100% oxygen, increased flows, and the bagging circuit, because now I've got, multi-systemic problems. My phase 2 is that I'd call for the anaphylaxis box because it's most likely an anaphylactic reaction. I've gone straight for the most, serious diagnosis, because it's better that I just treat that at the expense of anything else that's going on, because that's, the most deadly thing. If it's not that, it's fine. I've overcalled it. We just go back to normal. Finally, phase 3. Sorry, this is actually phase 4. Could someone tell me what they think their immediate priorities are? Where could you allocate teams for those multiple management threads?
I think it's just important that when you're in the room and you work out who's in the room with you, what their certain expertise are, what people feel comfortable doing. Is there somebody that's better with, putting in a cannula versus managing an airway, and making sure that you're kind of working as a team to work out who's going to be allocated to what role, and making sure those roles are really clearly defined.
That's really... That's absolutely right, because in any given situation, you may have different expertise. So let's say for this example, you definitely do that. You go, as you're allocating tasks, you go, are you familiar with doing this? Great. Yes, you can do that. Now, let's say you have all the expertise and that's given as brilliant, but there's no initiative. Kind of one of the things we say in SIM, your supporters will have great expertise, but no initiative. What are the priorities you would assign certain things? And one of them was great. You said you'd assign someone to cannulation, so big drip access, and maybe an art line would be one team. What's another few priorities for anaphylaxis management?
Well, I think you just, with all of these sort of situations, especially at a junior level, you just do get A, B, C, D, E. So you assign everyone to one of those categories, so that somebody's managing the airway, somebody's managing the breathing and auscultating the chest, somebody's, doing the cannula, getting the ECG, getting the drugs ready, getting the adrenaline. Somebody's, doing D, somebody's doing E. So everyone's kind of allocated, and you've and continue to reassess those, and which is the leader's role.
That's a really fair thing to say. So say if I haven't seen something and it's less familiar to me, that's a really great system, because then I avoid going too into something and making the wrong probability gambit. Once you get comfortable with certain situations, you'll find that you'll be able to target things in a slightly more specific way. For example, I'd cease the trigger. Oxygenation is a very particular thing, because it's oxygenation plus bronchospasm management. So it just makes it more specific to the anaphylaxis situation. Volume resuscitation is its own thing. And then adrenaline is its own thing, because those two are now very big tasks. One is pumping 2 liters straight in, knowing that 2 liters could extravasate in the first 10 minutes, so giving even more fluid. And another person is there drawing up adrenaline, giving boluses, doing an infusion. Finally, monitoring in lines, again, its own task, which would come under circulation, but because it's its own task, I need people to be just onto that. Acting as leader, I would allocate my team to these tasks. Each of these priorities has a story to tell. So just to give you an example, oxygenation, I'd turn up to 100% oxygenation, increase flows, bag the patient, check for any bronchospasm with auscultation, and give salbutamol as required, and use use lung protective strategies for an obstructive ventilation pattern. So, high IE ratios, minimize pressure to minimize barotrauma, maintain oxygenation, and permissive hypercapnia. And these are all the kind of things I'd talk about. Volume resus, as I mentioned, 2 liters straight in, keep reassessing, keep giving volume. Adrenaline, titrate up to effect, running an infusion from 10 to 20 mics per minute, drawing up 3 milligrams and 50 mils of normal saline or dextrose. So you can tell the story of each of these to completion quite quickly once you get used to it. Again, pretty advanced stuff, but there's no reason why you can't learn this for each of these crises. And if you don't know the detail, you can still frame it in a way that looks good. And if you're not sure, ABCD is absolutely the right way to do it. So Nadine, you're completely right about that.
Can I ask something? I know this isn't the point of this section.
No, that's right.
If you're worried that, like say you're maintaining them with volatile and you're
Yes.
concerned that the volatile agent is the trigger, so you turn that off. Mm-hmm. Where in your priority does making sure that the patient has a sufficient degree of hypnosis fall into all of this?
That's really great. So that won't come into this situation because volatile I think it's essentially unheard of. I'm not going to say impossible, but unheard of that would cause anaphylaxis, whereas propofol has a 1 in 60,000 of anaphylaxis, which is, again, very rare. Thiopentone's 1 in 10,000. Muscle relaxants are around 1 in 3, 5,000, 10,000. But that is really important in, say, malignant hypothermia. The trigger is succinylcholine and volatile. One of my priorities is cessation of the trigger and institution of other sedation, which is the propofol infusion or midazolam. So that's a really good question, and it would be its own task depending on the crisis, and that's particularly a problem in malignant hypothermia. Good question. So again, I run management in parallel like a real crisis. This allows me to organize my thoughts and organize my team in a really structured way. Just imagine, and again, not to labor the point, a crisis is very complicated in real life and very complicated to talk about in an exam or to your consultants. If I'm able to, hit these points, phase 1, blah, 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 phase 2, temporization, phase 3, I think it's anaphylaxis. And now I'm going to hit all the points of CRM. And it sounds like I'm getting all the points in there without just constantly talking about stuff in a disorganized fashion. Hopefully this works for you like that. This is definitely the way I think of crises, and I hope that comes across, that it's quite easy to do after a bit of practice. So here are the parallel storylines. Feel free to take a photo of that, but again, it'll be up on YouTube. Just know there's not much in each story that you need to know. This is, each storyline can be quite straightforward. Let's keep trying with this. So yeah, complete the CRM picture, allocate staff, check task cards, reevaluate, second opinion, avoid fixation errors, and mindful of the hospital's resources, I would call the adult retrieval service to help locate an ICU bed. So let's try this, but just because the point of difference here is stating the multiple priorities, the next few exercises we're going to do. So the next 1, 2, 3, 4 exercises we're going to do before we wrap up is literally just going to be stating these multiple priorities in any way you think they exist. Again, I just want you to try and commit to what your teams will be doing. This is the best strategy to create a consultant level real life answer. And let's identify those with a coordinated approach. So 50-year-old female for lap hysterectomy. This is a bad situation. On inserting the Very's needle, which is a sharp blind needle, blind inserted needle, you notice a sudden drop in the end-tidal CO2. So I'm just going to give you the phase 1. So, you scan the patient, you check the reading, you call for help, and you think that this is a potential crisis due to puncture of a major vessel and or gas embolism. So horrendous problem here, and happens very rarely, but you hear this happening maybe once every 5 to 10 years. I want you to turn to your partner, and in a minute, just tell each other what your multiple priorities are.
Sorry, Lahuru, what were the vitals there on the first slide?
Oh, let's just say they're really bad. So there's tachycardic, sudden end tidal drop, meaning there's no very low cardiac output. Blood pressure cycles and it's 50. Just imagine what this looks like. The needle's in the vessel, the inferior vena cava, it's ruptured it, and now I've put gas into that as well as rupturing the vessel. This is badness. The definition of a crisis all over this. When I think about this case, again, this is the most practical way I can think of this case. I've got now a vessel that needs repairing. So not only do the surgeons need to repair that, but they're not vascular surgeons. So I've got to get, if they are not aware, I've got to get the nurse in charge to call a vascular surgeon or a general surgeon to do laparotomy and repair the vessel. That's a whole team in itself that I want to take a bit of ownership for, because surgeons might get task fixated. You're very right about circulation. So circulation for me is all about fluid resus, which means 3 to 4 people managing blood, checking blood, administering blood, running a level 1 or something else, and then going and getting blood and writing up slips. That is a massive task if anyone's done that, while I might just manage the blood pressure. Airway is generally already managed because it's got a tube in, so I'm not too fussed about that. This patient dies not from airway oxygenation stuff, but all this other stuff. Finally, with air embolism, this patient is likely to arrest. So air embolism management is a whole sequence of steps, which again, you can read about, but it involves supporting forward flow, decreasing the size of the embolus with 100% oxygen, somehow preventing an airlock, and CPR to break up the air embolism and promote forward flow if required. Those are the 3 ways I manage this. But again, very advanced stuff. But you'll get what I mean when you look at these crises, that this way really tends to allow you to organize your team and your thoughts in a logical way. Again, if you're not sure, A, B, C, D is a very, very good way of doing this. You'll end up dividing up C into the appropriate tasks that way as well. Here's a bit of a tricky one, laminectomy in prone position. So your patient's prone, which means that they're facing down through the table, so very hard to get to the tube. The ventilator alarm shows a loss of pressure and the endotracheal tube looks dislodged, and the patient had a previous grade 3 airway. I want you to think about that. Take a minute. How could you manage your teams to make this airway better? Again, really advanced stuff. Some of you may have never even seen these operations, but again, it's just being exposed to this thought. Get the answer wrong, right? Who cares? This is about just thinking about it in a different way, which makes CRM really relevant to you. So think about this. You've lost the airway. This is horrendous. You lose the airway. The patient is dead within 5 minutes, right? So gain hemodynamic. You want a few things. You want the surgeon to gain hemodynamic control, and you want to manage the airway somehow. So I've got the immediate priorities here are turning the patient supine, which means that a technician, we need the bed in, you need the surgeon, and you need assistance. That has to happen, 5 minutes ago. So you need everyone in that room just to turn the patient, because all I've got right now is the ability to try and get this airway, and that's going to take all of my focus. And then when I think about regaining the airway, it's exactly what you said. I need to make sure that this patient has all the adjuncts to make this happen. So I'll have the LMA and bag mask all ready to go, even trying to get underneath to do that. And then once they're flipped, I got to make sure there's a video laryngoscope, because as we mentioned before, this is a grade 3 airway. And a grade 3 airway is a difficult airway in the best of circumstances, let alone when the SATs are 50% and the tube is already dislodged and there's all this edema around there. So again, I can allocate my teams to turn the patient, get the surgery done ASAP and just wrap some plastic over it, do my standard airway stuff, and then get a CMAC ready, video laryngoscope ready. 2 more cases. 35-year-old, G1P0, 37 weeks, presents to the maternity ward with abdominal pain. And this actually happened to me, funnily enough, after running a sim on the very same case. So that was just one of those really random things that happened. Blood pressure 70, heart rate 140, sinus tachycardic, past history of a large fibroid excision. So they've got this previous excision making the wall really weak. After 1 liter of fluid in the ward, the HB on the venous gas is returned with a HB of 60 with presumed uterine rupture. Again, 1 minute, talk to your mates about what you do with this patient, priorities-wise, teams-wise, in the maternity ward to solve this problem.
I guess, sorry, at this point, are we in theatre already?
No, we're in maternity ward. Good question.
In maternity, okay. So assuming this is like a Met Cholera Code Blue,
Yes.
making sure that we have, enough people available, enough hands around, getting more if necessary. Making sure that theatre's aware and that she's being rushed there.
Fantastic.
In the process.
That's a whole thing in itself. Arranging theatre is a whole task you can offload to the consultant in charge and the theatre nurse. So really great that you've highlighted that. Keep going.
But to go back to the patient and just go through the doctor's ABCD approach. So I guess at this point we've got sort of two patients, mother and baby, to keep in mind. So making sure that obviously ONG and that peds are aware and present. This is a lady who's hypotensive and tachycardic and quite profoundly anemic, but still making sure that her airway is patent, that she's got good saturations before moving on to circulation. Making sure that we've got ideally multiple lines going in at once. We've got someone. So I'd like to allocate roles, making sure that someone's or a team of people are at IV access, someone is at airway, that someone is keeping an eye on the rest of her vitals, someone's scribing.
That's
making
good.
sure that someone can call the hematologist that say we're going to activate massive transfusion protocol.
And that's good.
Someone sending off a group at hold, ordering bloods.
This is now where I insert that the blood transfusion or massive transfusion bundle. So now I've got everything right. Is what you said is absolutely right. The fact that I would go through my Dr. ABC approach because this is now a sick patient needing stabilization. The thing about with seniority, what you'll get to is the fact that you'll go airway, they're talking, done. Breathing, so that's 100%, they're done because there's not a breathing issue here. So you'll get to circulation very quickly, and that's why I go straight to that. It's very fair that you said ABCs, but you'll end up getting the circulation so quickly that this will all be about circulation, and now will be the massive transfusion bundle, which would be, do you want to have a go at that? What's the massive transfusion bundle where you can just say everything about that?
So I guess making sure someone calls the blood bank to organize massive transfusion protocols. So making sure she gets at least 2 bags of packed blood cells, probably type O, unless we have a group and hold that's already valid.
Yes.
And a bag of platelets. If she has other already identified issues on bloods, then replacing those, but otherwise sending off a fresh set of bloods. Making sure that someone calls hematology to let them know that we may need a lot more blood.
Yeah, good. And then I'd also think cell saver, perfusionist, multiple surgeons to sort that problem out, multiple hands, all of that stuff. Hematology, like you mentioned. Good. So fluid resus and activating massive transfusion protocol is one big job, plus all the other stuff, facilitating theatre access, and exactly what you said, neonatal care. Again, I'm being necessarily focused on this because that's what happens in real life. It's very fair that you say, I do a top to tail approach, ABCD, knowing that I'll sort out the airway breathing very quickly, but definitely fair to prompt that. That's really good. Final case.
Thanks.
40-year-old male, lap nephrectomy, past history hypertension, and a long-standing type 1 diabetic. On induction, you've given propofol, fentanyl, atracurium. You cannot bag mask ventilate at all in spite of optimization. And he's now a grade 4 view with a CMAC blade. So you've done bag masks, you've got a grade 4, and none of those are good. After optimization of your technique, SATs are now 90% after 3 attempts. The difference in this that I would state, as opposed to the way I was talking about it linear in the airway management section, is I can ask someone to prepare the surgical airway, scalpel, bougie, size 6 tube, while I'm doing the LMA. And I know that sounds like a really trivial thing to say, but I think it really matters that you've already told everyone, like you very correctly did, this is a CICO situation potentially. Can you manage a surgical airway for me? Yes. Scalpel, bougie, size 6 tube, please open that. I'm going to do an LMA to try and sort this out while you do that. There's no reason why you have to do it linearly because then it takes more time. And so this again is a crisis, and I can divide my resources and run separate teams. Good. Hopefully you don't have to do any of this alone for a long time. Again, the take-home message here, crisis of many tasks. So you need to supercharge your normal problem solving from before by clarity of priorities, parallel management, and lots of non-technical skills. We didn't drill the non-technical skills because they're common for each, but say you're practicing for your interviews or practicing for a Viva of some sort, just get used to saying that stuff because I think it'll really matter, especially into the future. CRM allows you to maximize on your knowledge. It's a learned skill that needs practice. And you'll see this when you're running sim, that it's just time and time again, we can always be better, but all crises, medical or otherwise, are handled a lot better with a CRM approach as well.